Hello and welcome everyone to Change Agents Learning and Action Network. My name is Deborah Huber. I'm the Executive Director of Health Insight Nevada, coming to you live from lovely Las Vegas. In this case, what happens here won't be staying here, as we are being joined by colleagues in at least 3 other states and in locations such as we have here in Las Vegas, and also online from parts hopefully that we'll know sometime soon, because you'll chat in and tell us about that. This is really a first-of-a-kind event. We call it a Mega LAN, Learning and Action Network. We really like acronyms, and it's pretty mega considering the number of people and the many ways that people will be joining in. So I want to tell you a little bit about who we are. Health Insight is here's a mouthful coming, a quality innovation network, quality improvement organization. We have that designation because of a contract we have with the Centers for Medicare and Medicaid Services. We have a number of other designations as well, but our real purpose for being an organization is to transform healthcare. As I mentioned, we have in-person participants in 4 states today, and we'll also be having some online participants as well. So a lot of what we're going to do today is about interaction and reaching out to each other, and so I really want to start with that. And so a couple ways that we could do this. For those of you online, you should be able to see your chat widget on your screen, so you can click on that and chat in where you're writing from, and what I'd like you to do is answer the question, what was it that made you laugh out loud yesterday? What made you laugh out loud yesterday? So you can chat that in. If you're in a room with another person or many people, what I'd ask you to do is turn to somebody that you don't know, introduce yourself, and tell them something that made you laugh yesterday. You know, maybe it was one of those crazy Columbus Day jokes. You know, those can really, they can really be funny. Whatever the case may be. And so we'd ask you to do that. Again, there's possibilities. If you just hang on just 1 second. Oh, go for it. You have 50 seconds to do that. Okay, all right. Maybe you got an extra laugh also. Vern, maybe ring your bell. Thank you. Well, I hope you shared a chuckle or a laugh with someone. I see our chat moderator laughing over here, so maybe there's one funny you want to share with us, Wyatt?
Yes, thank you, Deborah. We have Barbara chatting in that a resident yesterday started to feed the CNA for a change.
The resident in the nursing facility fed the nursing assistant instead of the other way around. I'll tell you, I laughed out loud yesterday. We have recently rescued a little dog 6 months ago, actually, and it just gives me such pleasure and joy. She's just really come into her own, and every morning she just runs around like a crazy, grabs her toys, takes them outside, runs back in. I mean, it's just a pleasure. It's just a pleasure. So thank you for doing that. We're going to have breakout like that every so often. I wanted to mention that we are providing continuing medical education, and we'll be providing the session is designated for 4.25 Category 1 credits. And these are the members of our planning committee and also our speakers. Want you to know that we don't have any relevant financial relationships that we need to disclose to you. So if you want CME or CE, you need to note that on the sign-in sheet. And if you register, if you're participating online, there was a note for you to be able to click that as well. We'll be sending your certificates in about 10 days or so. And again, if you have questions about that, you can just chat those in and we can give you some instructions if you don't know how to do that. Another good resource for those of you online is healthinsight.org/change agents. It's where you went to register to begin with. Okay. So again, I'd like to introduce your hosts for today. We're Health Insight. We're a regional healthcare collaborative, and our work focuses on transforming our healthcare system with goals to improve individual healthcare delivery, make healthcare more cost-effective, and to improve the overall health of our population. Much of our work is funded by Medicare or other federal or state agencies, but we also have private contracts, the largest of which is here in Nevada. Health Insight manages and operates the only statewide health information exchange, and that's a private organization called Healthy Nevada. So we at Health Insight have invited you to participate in a learning and action network, a LAN, as I mentioned earlier. Well, what in the world is that? Well, it turns out that all four of those words are really important. First being learning from our speakers, our thought leaders, and from each other. And so it's not just learning. It's action. So during the course of our time together, we're going to ask you to take some action to become a change agent and think about what actions you can take after you leave today. And then networking. We know we have many creative participants joining us today, and together we're creating a network of like-minded folks, of colleagues that are interested in transforming this healthcare system of ours. Folks who may think that they're facing unsurmountable odds or insurmountable barriers. But you know what? There's probably folks in this room and across the online that have maybe faced a similar barrier and might have just a suggestion for what you might do, or might have the answer to the question that you've been trying to figure out about a change that you want to make. And so it's really the network as we pool our resources, because this is a heavy lift. If we could have figured out how to fix our healthcare system, we would have done it long ago, because we've got a lot of smart people working on it. So it's really a combination of that learning, the action that we take, and the network that we create to do that. So this meeting is really only the first. It's sort of a kickoff. We will be doing these large mega lands on an annual basis, and then we'll have what I call the mini lands every quarter. We'll pick a specific topic about becoming a change agent that will help you create and develop those skills more, and we'll do those on a quarterly basis. And we'll let you know more about that, about how to register and how to participate in those. So as we seek to learn from each other, I wanted to make sure that you were aware of that we have a poster gallery. So in each one of our sites, we have posters that some of our participants have put together for us. Online, you also have a gallery to look at, and the address is right there for you. And so we really want to thank the folks that took the time to share what they've learned, to share the initiatives that they're participating in. I know that they would welcome your feedback, your questions, talking to them about how maybe you can replicate something that they've done in your own organization. So again, please take a few minutes at break or at our hour-long break when we end the plenary to take a look at those. So each of you should have your change agent action book. It's something you're going to want to hang on to. I'll tell you that right now. So it kind of gives you an overview of a lot of kinds of things. Again, for those online, you should have gotten the link to that in your email yesterday, but it's also at the Health Insight website. So just going to draw your attention to a couple of things. You can use the workbook to jot down some thoughts, jot down questions, ideas about things that you might want to do when you get back home. If you have particular aha moments that you want to make sure that you remember, that's a good thing to do within the workbook. So again, our today's agenda, our morning agenda, pretty straightforward. As I mentioned, we're going to stay on time and walk through a number of different elements here. When our Voice of the Patient session is concluded, I'll provide a wrap-up with a little bit more detail about what's going to happen this afternoon. Basically, we'll be taking a 1-hour break, and we'll say thanks and adios for just a little bit to our online participants. They will then rejoin us in the afternoon, dial in for our breakout sessions that we have planned. So people that are in a room with others, we'll have separate rooms for breakout sessions, and our online folks will dial in. And again, I'll give you some more instructions on that at the end of the morning session. Remember, we talked about action, kind of the big word in the title, action plan. So within your workbook, here's a template that you might want to think about and use. We're going to ask you at the end of the day to begin to prepare an action plan for becoming a change agent, for making those changes back home in your sphere of influence. And here's I think, kind of a thought-provoking, ask you some questions about things you'd like to change, people you've met that you'd like to follow up with, posters that were interesting to you, and good ideas that you've gained. We'll have the sessions where you complete those facilitated by a Health Insight staff person, so you can get some assistance with that. We're going to ask to collect those, and so that we have an idea of what you're working on and what technical assistance we might be able to provide you with that work. So that'll be at the end of the day today. Questions and comments. Because of the way that we're set up, we're not going to be able to take live questions like you might normally just raise your hand and ask the question or comment, but we still want those questions and comments, and we've got, again, a number of different ways for you to ask those. You can chat those in, and the chat moderators will let the speaker know what those are. In some sites, you have even a little cube that have these quick reference codes. The codes also are in your action book. And so if you can scan those into your phone and then ask your question or make your comment as well. If you're in person, you should have some note cards in front of you with a pen. You can write down those questions and comments, raise your hand, a staff person will pick those up, take them over to the chat monitor, and they'll get chatted in that way. You can also use the QR codes if you prefer to do that as well. So please don't hesitate to ask those questions and share those comments, and we'll take them to the extent that we can. It's likely that you might ask more questions than we'll have time for. Our plan is to answer those questions and post those on our website next week so that you'll have that opportunity to get that answered. Okay, here comes another fun part, all right? So next time, here it's ready to vote, okay? No politics involved, though, okay? So here's what we're going to do. The question is, when is the last time you took a full week's vacation from work? When's the last time you took a full vacation from work? Okay. So your possibilities here are A, I just got back from vacation. B, the last 6 months. C, last year. D, what's a vacation? Okay, so those are your options. Now, to enable to vote, You can do this in a couple of ways. You can, again, go to the pollev.com that you see listed on here, Change Agents LAN, or you can text it in. And let me give you the instructions about how you do that. So in the text, in the to section, the address to, you put in Change Agents LAN. Change Agents LAN. It's not case sensitive, but it is one word. Okay, so you type that and you'll get a message back from Health Insight. Then in the to box, you're going to put the numbers 22333. 22333. And then in the message, you'll put what your vote is, A, B, C, or D. Give you a minute or so to do that. Do we have success? Can I see some nods? Yes? Success? Yes? Okay. So let's see what we got here. All right, so I'm pressing my slides to see my results, and I'm getting nothing here.
If you push it too many times.
Okay.
Go. Right, touch screen.
While we're getting there up there, I know you're interested in my vacation. And so I did go in the last 6 months. We went in August. And we went up to Vancouver. You know, it was really, really hot here this summer. It started getting hot in June and way too hot. And, I hadn't been to Vancouver before. So we went to Seattle and drove up to Vancouver and, over to Vancouver Island and the flowers. And it was just fabulous. I highly recommend it. And I highly recommend vacation. There was a lot on the news actually yesterday. I noticed that, there's some of the companies are giving unlimited vacation, and that's kind of freaking people out when they take less because they just don't know what to do about that. But it did also said that about 50% of us don't take all the vacation we're given, and about 60% of us work on the vacation. So I don't know if that's really a vacation.
Just go ahead and go.
Okay, and tell her I've got till 10 after, I think. Okay, well, I guess someone will tell me what the results of the poll are, and hopefully we can get that fixed. Oh, we have them over here. Thank you.
Yes, I can provide those results.
Thank you so much, Wyatt.
Excellent responses coming in on that poll. We have a total of 170, and it continues to climb as I'm watching, with the greatest number having taken a vacation within the last 6 months.
Oh, good. Thank you. I wonder if we asked in the winter if it'd be the same, or people go on the vacation in the summertime. I don't know. Anyway, another way that you can reach out is to tweet. So if you're active on Twitter, we would ask you to use this hashtag ChangeAgentsLAN, and talk about your experiences today, what you're learning, what you're sharing, what you're thinking. So again, we have lots of options. We can actually talk to each other if you're in a room with somebody. We can chat, we can vote, and we can tweet. And now I've lost my Tracy. But I'm going to start by keeping you on your toes here. Well, I still might need some assistance here. See if I can get rid of this. Okay, so change agent, that's what we're all here about. And so here's some ideas. I'm going to ask for quiet in the room if I could. Here's some ideas about what a change agent is. I think it's somebody with a vision for what can be, and who can tap into the strengths of others and see how they can be used in a way to work toward a common purpose, not maybe in the same way or with the same exact idea, but moving us forward anyway. This doesn't have to be the person with the ultimate authority in your organization. In fact, most of us here who want to be change agents are not the authority in our organizations, and that doesn't matter. I think it's a person that asks tough questions, that questions the status quo, and says, "Why not?" A change agent leads by example and takes risks, even suspends disbelief that, you know what? The healthcare system has been the way it is for so long. Can we really make a difference? And the answer to that is yes, absolutely so. You can be that change. You're here today to get some strategies, some practical advice, some ideas about what we might do differently where we work, and to begin to talk together and network about what needs to happen. So I'm just going to ask you today if you will commit to being the change you want to see in our world. That said, we're going to turn it over to our first speaker. It's my great pleasure to introduce one of my favorite change agents. If you watch any national conferences on healthcare reform, payment reform, you're likely to see him, whether it's on a panel for the Brookings Institution or participating in the National Quality Forum or on a program for Medicare. In addition to all of these other positions he holds, some listed here, we know him as a quiet and thoughtful man, a man who inspires followership, and a man who is a man of vision and integrity. It's not the Pope. It's our own Mark Bennett, President and CEO of Health Insight. Mark?
Just going to take a minute here to adjust this, I think. Apparently I'm a little bit taller than Deborah, so I'm also really grateful for the opportunity that I have to be with you here today, and to spend a few minutes with you talking about how healthcare payment reform affects our future and the opportunities and the threats that it brings to us. I thank you, Deborah, for that very kind introduction. I appreciate the opportunities that I have to be involved in this space. I have to tell you that I don't consider myself a true expert in healthcare payment reform. I'm not really sure there are experts yet. This is very much a field in flux. There's a lot of stuff going on, and there's a lot of people working, but there are not a lot of perfect or clean answers. And the results that we're seeking are more aspirational than they are things that have arrived and that we're enjoying the full benefits of at this point. But I do spend a lot of time with people who are working on this space. And I do have 25 years of working and trying and sweating and failing and succeeding at trying to bring about change at a community level in our healthcare system. And I have the scars to show for that. Many of them are scars related to early efforts to try to change how payment works in our system. And so I guess that makes me, in some fashion, an expert. And so I'm grateful for the chance to be here with you. Today I'm going to move through a number of slides, and I'm going to do so fairly quickly. We'll have some time along the way to talk at your tables about vision a little bit in a few minutes. And we're going to try once again to do a poll, so hopefully that will work for us and we'll be able to get a little input from the broader group. But there won't be a ton of time. And because of the nature, there won't be a lot of face-to-face interaction or direct questioning interaction. We'll have some questions at the end that will be moderated by Wyatt through the polling feature. So if you have a question during the course of the presentation, we want you to write it down on one of the pieces of paper and hand it to a Health Insight staff member. We'll take it and we'll enter it into the polling function, and they'll be available at the end for questions. I've also put my email address on this opening slide so that we can continue the dialogue after today wherever you are. If you have questions or you want to engage, I'm happy to engage with you over email or in a future opportunity. I want to begin my presentation today with a small analogy. This cell phone belongs to my mother-in-law. She was goaded into buying it by her children and her grandchildren. And I think she was perfectly fine with the little, simple cell phone that had a keypad on it with all of the numbers she needed to dial. But her kids didn't think that was near cool enough, so they convinced her to go and get an iPhone. And, this is a really powerful tool. It's a great resource for managing information and for managing communication. But sometimes we lack the vision or the understanding of how to take full advantage of that capacity. It can help us solve problems, but we lack the ability or the desire or the capability to really take full advantage of that. And as a result, sometimes we turn such a powerful tool into just a bulletin board. When my mother-in-law got her iPhone, the first thing she did when she got home is she turned it over and she taped a calendar onto the back of her iPhone. She didn't understand that resource was almost instantaneously available inside the iPhone, or at least she didn't understand or believe that she would be able to quickly come to use that tool. And so instead, she reshaped the tool to something she did understand and was familiar with. In some way, this is not unlike our situation in healthcare. We have what I think is almost unlimited potential to alleviate suffering, to improve lives, to provide dignity to people. But collectively, we sometimes limit our capacity to act on that because we don't have the vision or because we don't have the tools that are necessary to utilize the full capacity of healthcare to meet those needs. And we also tend, and I think this is important as we begin and discuss this presentation, we also tend to take that transformation that we're engaged in and reshape it back to something that makes sense to us in our former world, as opposed to really embracing vision and innovation and moving forward to change the system. Change is hard. Change in healthcare actually is really hard, not just hard. It's really hard. I've not known of any more negatively resilient system anywhere in the world than the American healthcare system. It actively resists change, and there are forces at play that are very powerful. American healthcare represents a fifth of the U.S. economy. And there are lots of people, most of us in this room, frankly, who draw a paycheck every week and are dependent upon that system. So it's not surprising that making changes to it is difficult. Most of us, I think all of us working in healthcare, want to see healthcare transform. That's not the issue. I think the real issue is we want to see it transform in ways that make our particular part of the system work better, or our lives easier, or our work more enjoyable and more focused. And this is the important and, I think for all of us, almost all of us, our second best choice to the change we want, the way we want to have it happen, is status quo. And that's why healthcare is so hard to change. It's not because people don't want to see it change, but the visions of what we want to see change are so varied and so different. It's also true that the pace of change in healthcare is not smooth and even. It's more like a pendulum going back and forth. Sometimes you feel like you're making progress, and then it just kind of moves back to the other end of the fulcrum. It's also capable of very sudden shifts that change your world overnight. And so it's not just a stable system at all. And then finally, the last thing I'd just comment for you to begin, sometimes even when change is happening, it doesn't feel like anything's happening at all. I hope through the course of our discussion today, you'll get a sense of how we are close to one of those sudden shifts and that a lot of change really has been happening. More than a decade ago, the Board of Health Insight challenged us to move beyond creating small incremental changes through our projects and to look for ways to influence the larger system, to begin to reshape healthcare to make it more affordable and to improve the overall outcomes. We developed a model at that point of interrelated efforts that we thought we needed to work on all at once in order to move beyond incremental change to transformation. These included simultaneously working on sharing clinical data across the continuum of care, optimizing the use of health information technology, using transparency of cost and quality data to enable and engage consumers and the broader policymaking community, changing workflow and care processes, engaging consumers in their own decision-making. And all of this had to happen in a system where payment worked to support that kind of change. It became very apparent to us that the transformation we seek could never be done alone, that it had to be part of a larger community effort, that people had to band together to make it happen because it was too complex and too multifactorial for a single entity to drive. Today we've been asked to talk about what it means to be the change. That's the theme of our conference today. So what does it mean? Well, to me, it means that all change is personal. In the end, you can only really make changes to your own work and to your own attitudes and to your own views of how you engage with others in the system. Each of us have to make that choice, and when enough of us make it together, the system will begin to transform in the way we want it to. So why do we need to transform anyway? I'm going to try through the course of today's presentation to give you a little bit of data about why we need to change. But the upfront message is we need to change because everything around us is changing. We have to change or we will be left behind. And our society cannot continue to afford the healthcare system the way that we continue to operate it today. And third, how do we begin? At the end of the presentation, I'll try to offer you a few ideas about where you can begin in order to make some progress along this path. This is one of my favorite quotes from a favorite childhood story. I'm sure many of you have heard it before. But in spite of what the Cheshire Cat said to Alice, the truth is you're never going to get anywhere useful unless you know where you want to go. No matter how long you keep walking, you still won't get anywhere useful. So what I'd like to do is ask us to stop here for a minute and talk together in small groups. There's a page in your workbook for those of you who have a workbook. Either talk individually or in small groups for just about 5-7 minutes about your preferred vision for the healthcare system. I'd like you to be as concrete as possible using this idea here. So how would your day be different as a provider or a patient or a payer or a policymaker if healthcare redesign and transformation occurred, and how. And so just write a few things down, talk amongst yourselves. Again, if you want to, I'm going to try to gather some of these in. So at the end, if you could write down your idea and pass it over to a Health Insight staff member, we'll also enter it into the chat and can be part of our larger discussion. So we'll take about a 5-minute break now, and I'll give you a 1-minute call as we come back together.
But in the poll, or in the, it has to be in the presentation. You have to restart. You have to restart. I don't want to restart.
What's next?
I don't know where Tracy is, but now it's saying you have to restart.
We're about 1 minute away from restarting, so if you could work towards writing down your best idea and submitting it in, that would be helpful. Okay, we're going to get started again, so if I could have your attention back up front in the room or wherever you are, I'd appreciate it. So thank you for taking some time to talk about your vision and the potential of the system to transform. If you write down your ideas on a card and pass them to the moderator at your session, wherever you are, or if you're on the chat, if you enter them into the chat, then we'll be able to review those. And we'll come back to this after a few minutes, after I go through a little bit of data. I do want to begin by taking a look at some data to help us understand the urgency for change that exists, and a little bit about the efforts that are now underway to change how we pay for health care in our system. Paul Batalden said, "Every system is perfectly designed to get the results it gets." And this is a really important idea in quality improvement. It's the core of systems thinking. And as we go through these slides, I want you to think about what system produces these results, because I'm just going to walk you through some key results in the American healthcare system right now. Americans are overweight and obese. And more importantly, that the number of obese Americans is growing exponentially and very rapidly. Over the last 20 years, you can see tremendous growth in that. There are a lot of reasons for this, a lot of causes that we can point to. But the bottom line is this is a big problem for health and healthcare now and into the future. We also see diabetes growing rapidly. This is an expensive, complex chronic disease. It requires a lot of healthcare resources and attention. The growth of this and other chronic diseases has a profound impact on healthcare in the United States and on its ability to fulfill its core role of helping patients get and stay well. There's also in our nation substantial variation in healthcare quality and cost that crosses both geographic lines and within a given geography from one provider to the next. This has been measured time and again by numerous studies over time. And importantly, these disparities, these differences, while some things are improving, there's a lot of this that seems to resist change when we try to work on solving issues. Medicare and Medicaid have now grown to become the largest driver of healthcare spending. Together, they exceed considerably spending on defense, spending on Social Security, spending on the national debt. They are a major driver in our system. In fact, President Obama said it this way: our healthcare problem is our deficit problem. Nothing else even comes close. So consider that as we talk about some of the challenges that our nation faces. In addition, we're seeing a substantial shifting of costs as more of our healthcare system depends upon more of our dollars in the economy go to healthcare. The American system is becoming less and less competitive. This graph shows data you've seen, similar data from other sources, I'm sure, of how much of our GDP is spent on healthcare in the United States versus other countries in the industrial nations in the world. And that's leading to very large increases in costs for both employers and maybe more importantly, directly for employees as those employers attempt to limit their exponential exposure to the growing healthcare burden costs in their industry. Effectively, because of this continuing trend, the rising cost of healthcare has eliminated almost all real income gains since the turn of this century. It's all been eaten up in healthcare. And according to the President's Council of Economic Advisors, worsening health, medical technology arms races, volumes, overvalue work, these kinds of issues should matter to each person in the United States. Individuals, because it's stealing your pay raise effectively. So remember, every system is perfectly designed to get the results it gets. We produce a lot of good in the American healthcare system. There are lots of people who benefit every day from the interventions that come because of the system being designed the way it is. But these are also the results of the American healthcare system. And it points to the challenges that we face going forward. Given that environment and given that reality, the federal government is really engaged quite actively in the process of trying to influence and change the current performance in our system. This slide is taken from, I just want to make sure I get my notes in the right place here. This and the next several slides are heavily influenced by CMS. So I borrowed heavily from the work of Patrick Conway, who's the deputy administrator at CMS, and I think one of the chief architects of the federal response to the need for healthcare transformation and to payment reform. Basically, what you see in this slide is CMS is saying we need to focus on incentives. We need to focus on changing care delivery, and we need to focus on better information being available. Their goal, their version of the triple aim, better care, smarter spending, healthier people. And in order to achieve that, they think they have to really influence all three of those nodes at the same time. If you understand this context and you look at these next several slides, my hope is that what you'll see is where CMS is headed and also what their attitude is about that and why they feel both that it's successful and urgent to move ahead. The Health and Human Services Department set a very aggressive goal at the beginning of this year. The goal was to achieve 85, well, I think it's better in this slide to show. They went from 0% 5 years ago, care being delivered through an alternative payment model within the Medicare fee-for-service system, to a goal for 2018 of half of all Medicare fee-for-service being delivered within an alternative payment model. As you can see in those circles for 2014 and their projections for 2016, they're starting to make progress towards that goal. It is a very heavy lift. There's a lot of things going on, a lot of challenges that this environment creates. But I believe CMS will get there. I believe their will is sufficient. I believe their resources to act on this, to work on this problem, are sufficient. Some think unlimited. Maybe some who are negatively inclined say obscene how much money they have to work on this, but it's actually a very small amount of the spend. But they're very committed to it, and they're spending a lot of resource on it, and I think they're going to get there, and that is going to change our world, I think, in some fairly dramatic ways. It's not just Medicare that's working on these kinds of alternative payment mechanisms. This graph shows state Medicaid agencies who passed and are implementing alternative payment models for their Medicaid programs. Over just a few years, this graph grew from 0 to 15, and it continues to grow as Medicaid grapples with the challenges that they face. And it's not just government. In the private sector, in private insurance, this graph from Levitt Partners, and Levitt Partners is a leading private entity working in, among other things, study of ACOs and helping providers implement ACOs. They show in their projections that by 2020, 72 million Americans will be covered under an ACO at the current pace of growth in that area. Some of these efforts are beginning to show success. And some of us may think the successes or even the programs designed to change the payment system are a little bit pedestrian. Sometimes I feel like when I'm frustrated with CMS that they're really just dabbling in payment reform, that they need to move faster. But they have reason to believe they're making success. And the data to support that, I think, is pretty strong when you read it across the articles out in the system. And so there's a real interest and a real power, a real potential for the kind of change that I think CMS is looking to bring about. They've seen over the past several years what could only be seen as dramatic reductions in hospitalizations and costs associated with hospital care in the American Medicare system. And they attribute that at CMS to a combination of factors, including improvement programs like the QIO program that we're here under the auspices of today, or the hospital engagement network activities that have been going on around the country. They also attribute it to the quite modest payment incentives that were implemented under law over the last several years and that have put some pressure on hospitals to reduce unnecessary hospitalization. And they attribute it to some of the public reporting initiatives, the compare websites, other more aggressive programs, and more recently the introduction of qualified entities. All of these things have produced for CMS really significant evidence of change, of these programs working together to bring about the changes we seek. According to the CBO, we're also seeing the Congressional Budget Office, a nonpartisan group, a fairly sharp decline in the projections of Medicare spending, partly based on the changes in the ACA, partly based on the economy, partly based on these improvement activities. But these are evidences that the current CMS leaders are using to say, this is working, we need to do more of it. This is evidence we need to more aggressively move towards change. And so, armed with these successes, and frankly, feeling the pressure right now of the tension that their successes creates, what we're creating by working the way we are in alternative payment models is we're creating for providers the experience of trying to navigate on a lake with one foot in two different canoes, where you're trying to stay balanced, and part of your resources are going to fee-for-service, and part of your resources are managed under population health models or under more value-based models. And that tension can't hold. You'll tire, or we'll go back to the old models, or we'll have to move forward. And so CMS is saying, we're going to move forward. We're going to be more aggressive about this. So they've started to create more aggressive ACO models. These models are intended to be more predictable in their financial targets, provide greater coordination opportunities, and importantly allow beneficiaries to select their own ACOs. In turn, they allow for prospective attribution. A big problem in the current payment reform efforts in government so far is that attribution has only happened retrospectively and without people knowing about it, the patient knowing that they were being attributed to a given provider. It also is going to allow CMS to better reward quality under these new models and allow for enhanced collaboration and coordination support across the system. And finally, and importantly for smaller ACOs, they're going to try to smooth out the financial picture to allow the cash flow to work a little better for those who don't have very large amounts of resource available to them. This is all happening at the same time that Congress just passed the MACRA legislation. MACRA basically was the SGR doc fix bill. This is the law that did away with the annual dance that the Congress would do where they had said they were going to cut physician pay to follow the sustainable growth rate formula, and every year they would go to that line and then say, well, we're going to put it off and we'll make docs whole for another year. And then as it got bigger and bigger, so the rates, every time if they didn't act, in theory, we were going to cut physician pay by 20, 30, 40%, depending on how the overall economy was looking. And that was not a sustainable idea. It was never going to work, but they could never figure out how to change it. Well, this year they did. They passed that law, and now CMS is hard at work trying to implement MACRA. And MACRA includes really a strong push towards pay for quality or a strong push towards alternative payment models in two ways. One, it introduces under the MIPS system enhanced incentives for reporting and outcomes in value-based outcomes and quality, replacing the existing systems. It's a more demanding system. There's more reporting requirements. There's more work in it. There's also more dollars at stake for providers. But I think most importantly, they've also introduced a move towards alternative payment models that allows for incentives for providers who switch from just fee-for-service with these little riders to more aggressive models like accountable care organizations or bundled payments or global fee arrangements. And the payments for these are made on a lump sum annual basis, 5%. And way more important, I think, in the end for the typical provider, they provide, in addition to the incentives, they provide relief so that that provider isn't going to be overwhelmed by the MIPS requirements, which are demanding. And many providers, I think, will choose this path as they come to understand the alternatives available to them. In addition to payment changes, CMS is also working on making information more available. They've used the Quality Compare websites for a long time. Mostly that has been indecipherable information that nobody really used. But they're making a doubling down bet on information availability. They're changing the game in a number of ways, including more aggressive data releases like the recent release on by physician on Medicare charges that they're betting on that creating buzz and energy that can be used to change how we think about information and to change behavior of providers. They've also been more patient-centric in some of their more recent systems. So the star rating systems are tested as being much more likely by patients to be usable and useful to them. And they're trying to take advantage of the huge investment that they've made in electronic health record adoption to begin to use clinical data to enhance the public reporting data that's available. And finally, they've been made some investments to move that data not just inside of CMS, but out to entities in the communities where they serve who can, in return for getting that Medicare data, are tasked with public reporting it at the community level and at the provider level. So That's meant to give you just a little flavor of where CMS is headed and what's happening in the world around us as we think about payment and the importance. I want to pause here now and ask Wyatt if we can get maybe just if you could read one or two or three of the comments that may have come in.
Yes, thank you, Mark. We have a lot of great chats, comments coming in. A lot of them focused on the perspective of the patient, which is interesting. One of those, in my ideal world, healthcare entities would work collaboratively and closely to provide excellent care to patients or residents. This would include sharing resources and pooling finances to improve relationships and increase available workforce.
Thank you. So, any others? Anything? How about something pretty concrete? Anything in there that fits that? How my day is going to be different?
Yeah. So, here's one coming in from the Utah audience. Engage all team members who care for our patients to be more empowered to take a team approach. I think this helps us meet our patients' needs in a more holistic way.
Okay. So team-based care, patient focus. I'm really glad to hear that. We're going to come back to patient focus again in just a minute, but I think that's sort of a core principle. And thank you all for participating. I hope those of you who are online, this might be one way because we're funneling everything through that. It might be one way, excuse me. Sorry to race you through those. Where I think we can give those who have the disadvantage of not being in the room with us a little bit of advantage in the discussion as well at the same time. So thank you. So next I'd like to just spend a few minutes with you talking about principles that I think are necessary if we're going to be the change that's going to lead redesign. The first of those really is it's all about the patient. So we just heard from a couple of our participants about that. I think if we lose sight of this principle, we lose sight of everything in the end. There's so much of healthcare now that is aligned around the needs of the provider or the needs of the legacy system that we have in place to keep it running or the needs of the financial model that we're running. But that's always been backwards. I think we all know it's been backwards. And this is a great opportunity as we make this payment transition to think about redesigns that take the patient to the center, family to the center, that designs the system around the needs of the people who we're trying to serve ultimately. My belief is, in the end, that will make healthcare better, and it will make healthcare better for us that work in that system as well. The second principle is that bad processes beat good people every time. Now, this is a quote, or it's actually a paraphrase of a quote from Dr. Deming, the father of quality improvement. And it's really designed to remind all of us that it's the system every time. Almost all of the challenges we face are products of the system design that we've chosen. And it's almost never a people problem. Even though in our media-starved world and in the public square, we often act like almost all of our problems are designed to bad actors, are attributable to bad actors in the system. What Dr. Deming teaches us is, no matter how good the people are operating in that system, if you don't design a process that works to allow them to succeed, in the end, that system will overwhelm them and they will fail. It's a really important principle in making change happen. The third principle is that we need to eliminate waste. I'm really asking all of you to make substantive changes in our healthcare system. We can use lean technologies, we can use quality improvement methods to find and eliminate waste that may be present in our system. This exhibit from a health policy brief describes, and there are many of these out there, and they all come in about this same range. Basically, it says that between 1/3 and 1/2, and almost 1/2 of all healthcare expense is waste. And so when we talk about the changes we need to make in order to be more patient-centric, in order to be more team-based, if we could just figure out how to eliminate a portion of that waste, then we could do these additional things that need to be done without adding cost to an overburdened financial system that can't take more cost. It needs to make the changes without adding resources. So eliminating waste becomes the critical success factor in driving towards change. Now, I would say about this is not easy. This isn't like going to the butcher and cutting off the fat from the edge using a meat cleaver. The fat, the waste, almost all of it is marbled into the value add. And so the technologies that you're going to learn in today's session, that you're going to learn on your own as you move forward, are really what are going to allow you to make that transformation happen. The fourth principle is run to space. Now, this is really about the ability that separates good from great organizations, I think, and it's knowing where we need to be in the future and knowing how to get there. Wayne Gretzky famously said, "A good hockey player plays where the puck is. A great hockey player plays where the puck is going to be." And that's a really powerful concept. Before I ever heard Wayne Gretzky say it, though, I heard Don Berwick say, "Run to space." Now, he made this analogy very real for me in his own style that is really powerful. And I don't know if you ever heard him give a national forum address at the Institute for Healthcare Improvement, but it's really a pretty impressive thing. In his 1995 forum speech, which was one of the first I ever heard, he described his experience coaching his daughter's fourth grade soccer team. And after a lot of characteristic humor, dry humor and some, kind of real wit and wisdom imparted in the course of that, he showed how the team's success on the field and by extension our success as leaders in healthcare depended on running to space, on being where the ball was going to be when it was going to be there, not on just chasing the ball around the field. And he also described, and this is a critical part of his talk for leaders, this notion, this importance of understanding how the game is played. This is a non-delegable task. You have to know as a leader how to make improvement happen, how the process works of changing the system. And if you don't do that, you're never ultimately going to be able to be successful as a coach or a leader in our healthcare improvement efforts. The fifth principle is don't fear failure. In fact, failure is a necessary part of improvement. It's the only way, it's one of the best ways that we learn. It's perhaps not the only way that we learn. This graphic is taken from a report on the 100,000 Homes campaign. Sarah Woolsey, our medical director in Utah, shared it with me, and I thought it was really apropos to the principle we're talking about today. In this example, I think you can see the same kinds of things happening in healthcare that were part of their discussion about homelessness. That the mottos, the worldviews, the beginning premises that we operate with, the protocols or processes we run, the use of data, what we do when things go wrong, how we follow up on mistakes. The difference between failing as an outcome and failing as a catalyst to improvement is notable, and it's really important for organizations and for individuals who are trying to lead change. Number 6 is respect the limits of rules and incentives. This is really important to me in a talk about incentives, really. Ultimately, that's what I've been assigned to tell you is, hey, financial incentives are going to change the way you behave. And as you lead change, I hope you'll understand that there really are limits to those rules. This applies to incentives. It also applies generally to rules. So the Checklist Manifesto, I don't know if you've read this book. It's a wonderful piece of literature. It shows the value of standardizing processes, and it shows that the benefits of building checks into our system that are respectful of the limits of human memory. Our ability to sort of keep things in presence in our minds is limited, and so the use of checklists is a really powerful tool to drive change. But standardization needs to be understood and respected as having its limits. If not, it will always lead to bureaucracy, and bureaucracy will always stifle innovation. So we need to be respectful of that. Similarly, in the incentive space, better alignment of those incentives and better efforts in that space will help us as we try to change and drive towards cost management. It's critical to help us align and move to the results we seek. But I think we also have to be really vigilant here, because at its base, and there are plenty of people in the political environment we work with, and even in the debate about healthcare from a policy standpoint, who are of the view that it's all about incentives, that if we just change the incentives, everything will be better. Well, I think we as an audience are sophisticated enough to understand the limits of that idea. In fact, what we want to be vigilant against is that transition where we reduce the professionalism and the moralism of individuals trying to serve people down to, hey, it's just about the money. They're Pavlovian in their response, and that's not the case. That's not what we're trying to do. My view is what we're really trying to do is get financial incentives to the point where they can basically be neutral, so they don't harm our ability to pursue the right thing in the interest of our patients. I'm going to move fairly quickly through a couple of other principles here. Deming said, management's overall aim should be to create a system in which everybody may take joy in his work or her work. That's a really important part of a successful healthcare system. And I don't think there is a lot of joy in the American healthcare system the way it now operates. Far too many people feel like they are joyless, like the joy has been sapped right out of them. So, I want to test that theory for just a minute. So we're going to do a quick polling question. And I'm going to ask you again. Now, you should have if you already did the poll with Deborah before, then you should just be able to send a text to 22333 that has the number, because you've already registered. If you didn't do that first step, and then you need to register by sending a text, sending change agents land to that 22333. But otherwise, just take 30 seconds, register a vote, and then Wyatt will share some results with us as they come in. Where are you on the joy spectrum in your work today? Any numbers coming in, Wyatt?
Yes, we do, Mark. We're up to 200 and still increasing. Okay. If you were to see the bar chart, you would see starting at number 1 as their response at 6 responses, and then this huge lift up to number 8 with 50 responses, and then 9 and 10 dropping back down to 20 and 9.
Okay.
8 is the winner.
The peak of our curve. So we have a lot of joy in our work in this room, comparatively, and I think that's great. I think that actually speaks to the energy that you bring to your work. I hope that our system can help you support and continue to grow that because it's essential to success. I'm almost out of time, so I'm going to be quick about the last few slides. This is a statement from Peter Drucker. Culture eats strategy for breakfast. And, that's true. And Peter's not the only one who said it. In fact, it's been said by lots of leaders in healthcare over the last, lots of leaders in business over the last 25 years. It's become almost a trite, popular phrase in the healthcare environment. The reason it's so popular, though, is it's really true. And it's one of those things that leaders in organizations, every time I encounter this reality, it's really humbling to me, because what it says really is you're not very much in control of this beast. And I mean, that's really what it says, because I can affect strategy, or at least I can affect what our organization's strategy is, but I can only influence culture. But it also says if I work on influencing culture and make that my strategy, I'm more likely than not to succeed, and the rate of success is going to be much faster. I want to close with just two thoughts, reiterating transformation is coming. It is both necessary and it's inevitable. You're not going to be able to stop it. If your goal is to ride it out, that's a bad strategy. It's not going to work for you. This transformation is going to come. So we hope you'll join with us in helping make it happen. And second, joy really is possible. You can do it in a way that makes your work much more enjoyable every day, makes it much more tangible to the success you're seeing. I was going to pause for a few minutes on the next few slides. There are several slides which we'll hand out that show a couple of examples of that at play, but I'm out of time. And so thank you for allowing me to visit with you today and spending time talking about this important work you're engaged in. Thanks.
Out of time. Well, I guess that would mean you don't have time for questions.
So I'm told I took too much time. I don't have time for questions, but I am sincere in my offer. So if you have a question that you want to ask me by email or engage with me, for those of you in the room here through the course of the day, I'm happy to visit with you. Thanks.
You do to me here. Oh, we didn't get to. That's okay. That's all right. Thank you, Mark.
Okay.
So now we're going to have a 15-minute break, and so we're going to be back promptly at 1:15. Again, let's chat. Online folks, just click on that widget on your screen. We'd love to see what you're chatting about, your experience, that hashtag #ChangeAgentsLAN, ChangeAgentsLAN. And if you're in a room with other people, please interact. And we'll see you back here sharply at 1:15. And online people, stay tuned. We'll be right back with you.
Take it down and bring it back up.
Oh, okay.
For the poll.
Oh, okay.
It's like you're really expecting
Scroll down to the bottom.
I don't know where my. Oh, I had to close this out.
Okay, yeah. We lose him again. Lose Terry. Okay, so then if we go down, you got to close PowerPoint all the way. Yeah. You had it in some kind of presenter mode?
I know, and it's so weird.
Yeah, okay. Looked like it loaded the ad in. That's good.
Oh yeah, so there it is. Now, actually, we need to go to our poll, or our presentation.
Okay, let's try this guy right here. Okay.
We were on slide 88.
88. Okay. So then we just do F5? Or what's the...
I don't know what the...
F5 will do it, but current slide. There it goes.
Oh.
Great. Okay.
Cool. Do we want to try it?
Yeah, sure.
I don't know how you move it. How do you go to the next slide? I think we got it, but we wanted to test it out. Oh. Are we on?
Thank you. Oh, wow. Okay.
I'm going to ask you to get to your seats, if you would, please. That's all right. That's all right. A couple minutes. That's not mine. Mine's down here. A little note, Mike.
Right.
Yep.
Clock is okay.
Yeah, this is my clock, and this is. Clicker? You want clicker? You want clicker or you want?
Or, yeah, I never, no. Okay.
Yeah. Okay, me too. Let's please take your seats and we'll get started. Yeah. So welcome back. Now I have the good fortune to introduce another great agent of change, also to many of us, both inside Health Insight and across the country. He's been a teacher to us and a mentor, and certainly a thought leader who regularly challenges conventional thinking. In addition to that, he's just an all-around good guy, and he's always got a great story or two. And so with that, Michael P. Silver.
Thank you. And to begin with, thank you all for coming today. On a bit of a personal note, thank you for what you do. This past year, my family has benefited from the efforts of people like you. People like you have given my daughters more time with their grandmother. And so we appreciate your efforts and what you do in healthcare. So I wanted to start with that. So today, a Learning in Action network meeting. Today is about taking action. At the end of the day, as Deborah explained, we're going to have a session. We're going to have an opportunity to review what we learned together today and how you might or might not apply that in your work. In the meantime, I want you to feel free to explore ideas together. Mark asked for your vision of healthcare, how that's going to look like in the future. Explore those kinds of ideas as with your colleagues and that sort of thing, and then with the idea that we'll commit to some of those at the end of the day. Mark also gave us a sense of the changes that are here and that are coming to healthcare. And I want to focus in this session on the opportunities that creates for us, opportunities to make healthcare even better. As Mark was saying, when we think about drivers of change in healthcare, created by payment and other types of reform, we think that there's a limited ability to really mandate or force innovation and improvement. Rather, much of what reform can do, the important thing it can do, is to create opportunities or to remove barriers to quality and innovation. Of course, removing barriers only matters if there's somebody willing to push beyond and see what's on the other side. What I'm getting at, our goal of better healthcare and healthier communities, depends on whether we are prepared to and whether we choose to push those boundaries, find out what's important. And you have a particular role, a particularly important role. People at the front line, people who are close to the front line in any system, in healthcare or any system, have a different perspective. You can see things and opportunities and areas where the system is misaligned that other people can't. So you have a choice. You have a role and you have a choice here. Mark talked a little bit about some ideas from the Institute for Healthcare Improvement, Don Berwick. They framed much of what we're after here as the triple aim goals. What we're seeking to do and what we have to do is simultaneously improve the health in our community, reduce the healthcare costs, and improve the experience of care. Now, among these three, the first one, improving population health, that's the prince. That's the prime driver here. If you get to that, you start addressing the cost problem in a real way. Moreover, I would argue that the best patient experience is not to get sick in the first place. So, okay. So, and you'll learn more, and I know that many of you are involved in our current programs, but these are some of the ways, some of the metrics that we're using to assess our performance or improvement on toward the triple aim. Among those, we're working in all our states to avoid preventable hospitalizations and unnecessary hospitalizations, reducing readmissions, preventing adverse drug events, depression screening, reducing the inappropriate use of antipsychotic medications in skilled nursing, and improving or increasing mobility in skilled nursing as well. So how are we going to get to those triple aim goals? I'm going to outline or propose some pathways. These are, by the way, not that controversial. There's a great deal of consensus on these as ways to get to the triple aim. First of all, and primarily, preserving and maintaining and restoring health, beginning with the person before they're a patient, healthy behaviors, healthy choices, that sort of thing. And then among people that are patients, are involved in the healthcare system, to promote self-care, active participation in their care plans. Better use of preventive healthcare, including primary prevention, immunizations, things like that, to keep people from getting sick, but also to support people making healthy choices. And secondary prevention, once people have acquired disease, make sure we use the best evidence and the best care consistently to care for them. And that idea of consistency, reliable, patient-centered, coordinated care. A great deal of the gap we see between where we are and where we'd like to be falls into that lack of coordination. We have all the pieces, we need to put them together. And finally, we'll talk about this a little bit more this morning, informed health care choices. Patients or those who make decisions on their behalf need to understand the benefits, the risks, and the limitations of the care that they may elect to receive or elect not to receive. Now, clearly, these pathways are going to involve more than just healthcare providers. So, let's see. We have aims. We talked about aims. We talked about pathways, and I want to propose some strategies. Now, we'll be working together in this, as Deborah introduced it, the QIN-QIO. Anybody remember what that stands for? Contract for the next 3.5, almost 4 years. There are going to be additional annual gatherings. We'll be working with you, providing technical assistance, those web-based support, other resources, that sort of thing. And we've identified some change strategies that we want to offer for your consideration. We think that these are high leverage ways to get to those triple aim goals. And they begin with patient engagement. You're not going to get very far in the triple aim that, on any strategy or any program that doesn't involve patient engagement. So we're seeking to increase the frequency of choices and behaviors that preserve or restore health, increase active participation in ownership of care plans. There's a process reliability. And by the way, we'll talk a lot more about patient engagement today, and there's a session this afternoon. Process reliability means that we have a plan for supporting patients and that we carry it out reliably, consistently. Complex needs. We recognize that this isn't a one-size-fits-all world, and so we have to have the capacity to identify what the true needs are for the patients and tailor the services that we provide to those needs. Health information technology, we'll be talking more about this afternoon, and that supports us not only in patient engagement and in coordination, but actually more especially in coordination as citizens in a healthcare system to share as appropriate the information that we have with others who have legitimate and authorized purposes for that. And then alternate payment. Alternate payment models are going to create and creating right now opportunities for us to better serve or respond to patients' needs. Some useful changes are happening right now, and we need to find ways to take advantage of those. So, and here's the simplified map. Putting this all together, and this tries to indicate some idea of causality, capture that notion that among the aims all the way there on the right are that triple aim, healthier people, lower cost of care, better quality of care, and how those relate to each other. We identify pathways that'll get us there and strategies. So, but what's missing from this map? Well, somebody's going to have to make it happen to execute those changes. And we need change agents. And I guess the cat's out of the bag, my friends. We're counting on you. And we'll talk about why that's a reasonable proposition, or why we hope that you will find that to be a reasonable proposition. We are going to work together, not just for encouragement and not just to share best practices or spread best practices faster, but we need to work together because the problems and the opportunities are bigger than any one of our organizations. To solve these types of problems, we need to collaborate. We will help bring effective change strategies that target high leverage critical functions. So, and together, today and beyond, we will be working together to build capacity to make positive change, to initiate change projects, to make sure that the changes we implement are self-sustaining. So if I haven't made it clear before, if Deborah didn't make it clear, if Mark didn't make it clear, we're looking to you to be the change agents. And you may have been offered similar opportunities in the past. Maybe you don't want to repeat that experience. And you might be asking, or maybe it was a positive experience, but you wouldn't mind it being an even more positive experience. So what's going to be different this time? A couple things. Technical know-how. We will, and we'll talk more about this, but we'll be bringing to the table Health Insight, connecting you with the best thinking in this field of how to make technical changes in healthcare processes and healthcare systems. Health Insight itself has invested almost 20 years of developing capacity and supporting providers making such changes. But also, I want to spend a couple minutes on the second point of change management. Resiliency, building resiliency into our change agents and into our systems, reserves, commitment, persistence when setbacks are encountered, and overcoming resistance. In order to pursue an ambitious program like we're talking about, we have to have the reserves to begin something new and hard and potentially hard and to stick with it. I want to include or show you a video. I think I know how to do that. We'll see if this works. Oops, it didn't work. And just a moment.
Hi, my name is Brian Sexton, and today I'm going to share with you the 3 Good Things intervention. It's a resilience exercise. It's our most popular resilience activity that we offer at the Duke Patient Safety Center. Let me talk a little bit about where this came from in this brief video. We know in healthcare right now, if you look across different professions, whether it's perfusionists, surgeons, nurses, administrators, people work in IT, administrative support, about 1 out of 3 folks who work in healthcare today meet the criteria for not mild, not moderate, but severe emotional exhaustion, otherwise known as burnout. So it's 1 out of 3. You look left, you look right, you look in the mirror, one of them is burned out. In primary care, it's over half. In emergency medicine, it's over 60% of them meets the diagnostic criteria for burnout. So it's a pretty significant issue in our industry. And one of the easiest, lowest hanging fruits, low cost to no cost intervention to work on this, from our perspective at the Patient Safety Center, is the 3 Good Things intervention. What is 3 Good Things? In a nutshell, the efficacy of 3 Good Things trends better than Prozac, but we'll talk about that here in a second. Where did it come from? Marty Seligman was the president of the American Psychological Association for 9 years. He's a clinical psychologist. He founded the field of positive psychology. He created the 3 Good Things originally as a gratitude journal where each night before you go to bed, you write down 3 things that went well that day right before your head hits the pillow. He covers this and other positive psychology interventions in his book Flourish, A Visionary New Understanding of Happiness and Well-Being. Let me break down 3 Good Things for you in a nutshell. Barbara Fredrickson's a psychologist who says the negative screams at you, but the positive only whispers. If you've ever noticed that it's hard to remember a good joke, then you understand that the positive only whispers. You will eventually be in your late 80s with full-bore dementia. You won't be able to recognize your own children in a police lineup, but if you hear a rattlesnake rattle, you'll think, oh, snap, that's bad, right? What is that? That's bad. I know that's bad, right? Because the negative stays with you. We are hardwired as human beings to remember the negative, to reflect on the negative, to notice and recall details from the negative. So the negative screams at you, but the positive only whispers. And we have a strong negativity bias as human beings. This is part of what feeds in to burnout, because it's easier to remember the heart-breaking moments at work every day than to remember the heart-warming moments. And every day there's a little bit of both, but we're tuned into explicitly the heart-breaking moments. So if we can remember, number one, we're hardwired to remember the negative. The second point we need to make from this is that we have enhanced recall of material that we learn or review or reflect upon during our last 2 wakeful hours. So what's the best time to study for boards? Not 10 a.m., 10 p.m. What's the best time to reflect on what's gone well today? Not at lunchtime. It's right before your head hits the pillow, as close to sleep onset as possible. Now, what you do during your last 2 wakeful hours is what you're going to recall in your dreams, and you're going to recall that information more accurately and for a longer term. So whether or not you're reading mom porn like Shades of Grey or playing Angry Birds on an iPad, that's what kind of sticks with you as you're going off into dreamland. Why not spend that time reflecting very briefly on what are 3 things that went well today and what was my role in bringing that about? Because the efficacy of this intervention is just so very powerful and impressive. So number 2, we remember things during the last 2 wakeful hours. So you want to do 3 good things as close as possible to bedtime. You should do it practically when you're in bed. Number 3, with practice, by day 4 or day 5 of doing 3 good things, you actually are going through your day noticing more positive things. Your heartwarming moments-ometer is finely tuned. You're catching them. You're noticing them more well. And saying, I can put this in my log tonight, because you've actually flexed a muscle and enhanced your ability to take in those positive moments. So by day 4 or day 5, you're actually noticing more positive. Not that more positive is happening, but that the positive that is out there is making it more readily onto your radar screen. This has been published. The original randomized clinical trial was demonstrated by Marty Seligman and his colleagues, where they demonstrated this in nicely controlled, kind of empirically rigorous conditions, and showed that 3 good things actually trends slightly better than Prozac and other SSRIs. Selective serotonin reuptake inhibitors work really well for people with severe depression, people with mild or moderate depression. They are actually no better than a placebo or a sugar pill. So the great thing about 3 good things is it works for severe, mild, moderate. It also works for people who have no depression at all. It actually enhances your happiness and helps you with work-life balance and reduces your burnout. So it works beyond just the traditional variables of happiness and depression. What's interesting here is in the original study that Marty Seligman published with his colleagues, if you look at 6 months post, if you look 6 months after having done this intervention, it looks like you're still on Prozac, even though you only did it for a week. We now know you should do 3 good things for 2 weeks, because you can make the effects of the intervention last longer by doing it for 2 full weeks. And we've got some tricks to help you kind of stick with it for the full 2 weeks. How do we do that? If you register with one of our 3 Good Things cohorts, the DukePatientSafetyCenter.com, www.DukePatientSafetyCenter.com, you can actually, you give us your email, we will give you an informed consent. If you agree to participate in the research, we will send you an email at 7 p.m. Eastern Standard Time that looks like this. Please follow this link to go to your 3 Good Things log for today. The next thing that comes up, if you press next, is would you like to share or not share your 3 good things? We do this because some people say things like, oh, today I took the stairs instead of the elevator. I'm trying to take care of myself, or I stuck to my diet. Other people say things like, oh, I asked for sex with my spouse tonight. I got it. Yeehaw. I'm so happy. You can see where some things you might want to share publicly, where other people can read it, other things you want to keep private. Let's say that you hit share. And by the way, 3 Good Things works whether or not you share, which is really cool. We haven't published that yet, but the effect is the same whether or not you share. And there are a lot of people who don't share who are voyeurs and go read all the comments of people who do share. That's okay. You're welcome to do it. You get an email like this. If you click on the link, you go to 3 good things, number 1, number 2, number 3. And then we have another activity. So you enter what went well today and what was your role in making it happen. And then we ask you to select from a pull-down menu, what is the positive emotion that best fits how this good thing made you feel? Now, you can fill this in. My 5-year-old swam across the pool at the YMCA today without any floaties for the first time. I'm so proud of her. What was the positive emotion? Pride. Good thing number 2, I watched a glorious pink and orange sunset behind rolling hills where the leaves are changing with these fall colors. It was just beautiful. What was your positive emotion? Awe and wonder. So you select that. You get to savor your 3 good thing entry from earlier today just by thinking, what was the emotion? That's what it was. It's kind of a nice little, it just takes a few seconds to do it, and it actually enhances the effect of 3 good things. Good thing number 3, I made my wife laugh today so hard that her eyes watered, and so did mine. You could put that under amusement. You might put that under love. You pick an emotion to go with it. When you're done, you hit submit. You're redirected automatically to a log of all the good things that were entered by participants the previous day. So you can see how other people use it. And seeing how other people use 3 good things can be very helpful and inspiring. It can keep you kind of on the path of doing it. The email reminders help. The ability to see how others use it helps to keep you doing it. The very first time we did this in the neonatal ICU, we actually found that these are word clouds on day 1 versus day 14 of 3 good things. They're talking less about work, less about time, more about family, more about home, more about husband. You can see that they're moving in the direction of more work-life balance. And the great thing about this was the first time we did it, we saw an increase in happiness and a decrease in burnout. So just the same effect. We started adding more variables to the cohorts. We did this next with our Duke internal medicine residents, found some very impressive results about not just burnout and depression and happiness, but also work-life balance. Essentially, these residents, these internal medicine residents, we announced 3 good things at noon conference. We had them register during noon conference for the study if they wanted, and then every day for the next 2 weeks, they got a 7 p.m. email from us that said, what were your 3 good things? And they entered it. We found lower burnout, lower depression in the post. They experienced fewer delays. They had less conflict with colleagues, fewer disruptive behaviors, and better work-life balance. They got home on time more often. They skipped fewer meals. They ate fewer kind of poorly balanced meals, and they reported better sleep quality. All of this is really good for your work-life balance. The greatest thing about this, too, is that the residents really enjoyed participating in the research. And when they were done, they're like, hey, I kind of like that 3 good things thing. What else you got? You got some more stuff like that? That was very encouraging. If you look across the Duke University Health System, these are 258 bars, 258 clinical areas and work settings across my health system, where you can see the percent of people reporting resilience. This is the percent of people, each bar is the percent of people who do not have any burnout, not mild, not moderate, not severe, not at all burnout. And it ranges from 10% to 70, 80% or more reporting burnout. When you look at internal medicine residents at Duke in the pre versus the post, they climbed up a quarter of the distribution in 2 weeks of doing 3 good things. We replicated this again when we did this with our patient safety leaders and mid-level leadership across the Duke University Health System, found even stronger effects as we start to kind of tighten up our methods and make this even more convenient, more accessible. These patient safety leaders across our health system went from kind of the mid-range of the distribution. They jumped up like a third of the distribution in just 2 short weeks. These are supervisors, managers, directors, medical directors, even senior leaders, vice presidents, etc. We found that 95% of these folks at the end of the study would recommend 3 good things to a friend or to a supervisor. So this is easy to do. It's fun to do. It doesn't take a lot of time, and it's easy to kind of encourage your kids, your spouse, other colleagues to participate along in it with you. In our patient safety leader cohort at Duke University Health System, we found significantly lower burnout, lower depression, higher happiness, better work-life balance, improved sleep quality, and there was a trend toward more sleep, but it wasn't statistically significant. But there was a big improvement in sleep quality, which is fantastic. 98% of our participants complete 3 good things within 3 minutes of starting it. We get that from the timestamps. So it doesn't take a lot of time to do it. It's relatively easy. It's relatively low cost. If you go to Duke Patient Safety Center website, www.dukepatientsafetycenter.com, and register with whatever cohort we have available for you on the website when you're viewing this video. I encourage you to take advantage of this.
I will finish this for him, I think.
Hi, my name is Brian Sexton, and today I'm going to share with you the 3 good things intervention. It's a resilience exercise. It's our most popular resilience activity that we offer at the Duke Patient Safety Center.
I think he started again.
A little bit about where this came from. Hi, my name is Brian Sexton, and today I'm going to share with you the 3 good things.
This is going to come back. In your workbook, there's some, Brian, take it easy.
At the Duke Patient Center.
In your workbook, there is there's some information links. We have made arrangements. If you are interested, you or to have your organization are interested in participating in this intervention, we've made arrangements for you to do so.
Hi, my name is Brian Sexton, and today I'm going to share with you.
We made arrangements for you to do so, sorry, the information is in your workbook. There it goes. See, I didn't do it hard enough. I tell people you push those buttons harder, and good things will happen. So, if you're interested in this, and I recommend it, I just went through it myself. Brian reviewed the science behind it. This is solid stuff. If you do sign up, please select Health Insight Change Agents, and then we'll be able to report back to this group your results. We won't know any of this is all confidential, of course, that sort of thing. We have... Oh, there we go. How about a quick poll? Again, the same methods, text or on email or the website or whatever you do with that. Is burnout a problem where you work? 3 choices. 1, burnout is not a problem at all. Minor and occasional problem. Burnout is a significant problem. We have a little bit into your responses. We got responses coming in? No? Nothing? Oh, yeah. People just don't care enough to... Okay. Oh, look at that. Okay. All right. Oh, wow. We got a lot of people weighed in, and we have a lot of people telling us burnout is a significant problem. This is worth addressing. It's worth looking into. In fact, what I want to do, I'm interested in that result. What I want to do is again, this is a workbook activity. I'm trying to. Oh, there we go. This is in your workbook, and it was one of my jobs to look up the page number, but I didn't do it. So it's on page number 2. Thank you. This, I'd like you to spend a couple of minutes. Why don't you go through a quick 3 good things inventory that's in the workbook, and then share your findings, share your 3 good things with people around you, and take a minute to talk about how could you promote the use of the resiliency tools or the 3 good things exercise where you work. We will take 5 minutes on that, and so we'll reconvene as a group at 47 minutes after the hour. So I'll give you 5 minutes. 3 good things. Talk to your colleagues. How else could you use this?
Sunday,
All right, we best reconvene here, here and everywhere we are. Sorry, thank you. All those good things. I know we want to share. We don't want to stop. In fact, it's a very good thing. We need to do more of that. Sorry, we have to. Sorry, thank you. To reconvene. So just Wyatt was telling me the final count on the polling, it looks like about 40% of the respondents that and over 300 respondents said that burnout was a significant problem where they work. Now that's an important outcome in its own right. But we're going to be talking about patient-centered care, and I would assert that if that's what we have, if that's the raw material that we have to work with, people that are burned out, we won't be producing patient-centered care. It won't happen. Those things are incompatible. So I would recommend and hope that you take advantage of the resiliency training, and we will bring more to that sort of thing to you if you're interested. So just a couple notes. One is, again, we're delayed. Maybe you've got the slides. I'll tell you about Health Insight Accountability. What can you expect from us? We're going to be creating learning opportunities, forums where you can connect with colleagues and other change agents seeking to make healthcare better. We are connected to through in the country and through other innovations efforts, what we think of as the best thinking in this field, and we'll seek to bring that to you. And then we'll actively support you through data and technical assistance, that sort of thing. That's our accountability. That's what you can expect from Health Insight. We have a request from you. As we said, we're looking forward. At the end of the day, this is about an action plan. So we're going to ask you this afternoon to develop a plan, something that you can commit to, even if it's only to tell people back in your organization about 3 good things that maybe they'll benefit from it, but you may push yourself beyond that. But until then, I want to ask you that you'll consider possibilities, including the possibility that together we can make a difference. One of the characteristics of a change agent is they know the difference between saying it's impossible and it can't be done and saying, I don't know how to do it. One of those things closes a door, and the other one is a starting place. And I think we're better served by that starting place perspective. So that's what, and you'll just have to be inspired by my words and not by my slides, because they're not keeping up with us here. So, and that takes us to the end of this session, and thank you so much. Deborah's going to introduce our next speakers, and we will actually catch up the slides. I'm sure I broke something. So.
I think you did break something. Well, the good news is our next speakers don't have slides, right? So it's my pleasure to introduce our next 2 speakers. They are affiliated with the Nathan Adelson Hospice here in Las Vegas, which was founded about 30 years ago or so. Nathan Adelson is the only nonprofit hospice in Southern Nevada and provides hospice and palliative care to over 350 patients every day. I'm pleased to say that they took such loving and wonderful care of my father and me and my mom for a good while, and we sure appreciate that very, very much. Nora Lunda, our first guest, is the Director of Diversity and Education at the hospice. And in 2013, she was the recipient of the Vegas Inc. Women to Watch Award. I think that sounds like change agent. I don't know. I think there's potential there, Nora. That sounds like that to me. Also, we're welcoming Laura Coleman, and Laura has been affiliated with the hospice for the last 23 years or so. She's had several family members cared for by their staff, and also has been a very active volunteer at the hospice as well. She's also very active in the community for many, many years and in numerous capacities. A woman, I think, who truly makes a difference. Please help me welcome Nora and Laura.
Good morning, everyone. I'm going to just tell you briefly about 1 minute about our new initiative called Deciding Tomorrow Today. You all should have a copy of this that is hot off the presses. It was actually delivered here this morning. Being in hospice, we see every day the results of what happens when people have had discussions about what they would want at end of life with their family members, when they've thought about what they would want, when they've written it down, when they've, explored the options about what their values are, what their priorities are, what quality of life is. We see how things go a lot more smoothly at end of life, how families are focused on caring for each other, on fulfilling their loved ones' wishes. And we also see the opposite when people haven't had those conversations, just how hard it is, families disagree, brothers and sisters stop talking to each other over their disagreements about, what mom or dad or the brother or sister, what they would want or what they said to one family member or another. And so we really feel that people should think about it, consider it, write it down, have these conversations. So we are launching our Deciding Tomorrow Today initiative, which is about helping people have those conversations, toolkits, conversation starters. And the first thing in any of all that category is our guide for providers. That helps people have the conversation, helps healthcare providers how to, start that conversation with their patients and family members. There's a guide for providers on talking to patients who have terminal illness and tips and things like that. So our website is not up yet. It will be very soon, decidingtomorrowtoday.org, and there'll be downloadable tools and things like that. So we hope that is a helpful tool for you all. And Laura Coleman has been a volunteer with Nathan Adelson Hospice for many, many years, and she has personal experience with this and that she's going to share with you. Thank you.
Okay. This is my mom. Okay. I'm going to put my mom right there. She's always kind of crooked anyway. Okay. Well, not like crooked in a bad way. Okay. And this is my mom's story. And I'm going to start with this envelope right here. And this envelope says, "Please open in the event of my terminal illness or sudden death. Evelyn Newman." And inside there's a piece of paper, notebook paper, and it says, "This is to certify that in the event of my having an irreversible illness, there shall be no life-prolonging mechanisms attached to my person or administered to my system. In other words, let me die with dignity. Thank you. Evelyn Newman, 7/29/80. And I've written down what I'm going to say to you, because I have a tendency to wander, and I want to make sure that I get my mom's story across to you. Okay, so that was written in 1980. So we're going to back up to October 8th, 1978. My father had open heart surgery. It didn't go as it should. And from October 8th to 1978 to February 8th, 1979, my father never left the hospital. He lay comatose, hooked up to wires, in intensive care, with no hope, no information. Day after day, my mother sat in the waiting room. 5 months, only the words, no change, no compassion. On a side note, that day, October 8th, 1978, my daughter was hit by a truck, and she was laying in another hospital here in Las Vegas, and she was dying as well, but she did come through. A year passes. My mom, at the age of 66, just 3 years older than I am now, sits down and writes that paragraph. She was healthy at the time. 1984, my mom's leg hurts, up by her hip. She rubs it constantly. She goes to the doctor, a doctor who was a friend of hers, but a doctor, and the doctor says, "Oh, Evelyn, you're just getting old." Really, that's what the doctor said, because I was there. She and I take a trip to Switzerland. She has good days and bad days. We spend New Year's Eve 1984 in Switzerland together. The trip home takes a toll on her. Her leg still hurts. January 1985, we go to the doctor. He sits across from her and simply says, "You have cancer in your femur," hence the leg pain. She heads down to San Diego to have her femur operated on, and while she's there, someone breaks into her home and steals everything she owns. But that's a whole nother story. Coincidentally, in this thing is also at the same time, she wrote down everything she owned at that time and who gets what. And guess what? That doesn't happen because it's all gone. Okay. She does her rounds of radiation and chemotherapy. They don't make her feel better. They just make her sicker. I'm the youngest of 9 kids. My mom goes to Virginia to spend time with my sister Jessie and her family, and my oldest brother Mike and his family. Ultimately, she wants to come back to Las Vegas. This has been her home for many years, and this is where I am and her favorite granddaughter, my daughter Jessica, are. Chemo and radiation aren't keeping her pain-free. She has a lot of pain. The doctor recommends hospice. At the time, Nathan Adelson Hospice was only one of 2 in the entire country. There wasn't much known about it. What I did know is that we're very modest people, and with the promise of a volunteer coming to our home on a regular basis to bathe my mom and look after those kind of needs, and the opportunity to have morphine administered to her to keep her pain-free, I hadn't read my mother's words yet. I didn't know until after she died, but what hospice promised was clear. The end of life journey was her end of journey in life was free of pain and with dignity. My mom was an incredibly dignified woman. She deserved that, and she got that. After 26 years as a volunteer with Nathan Adelson Hospice, I've seen something different, though. I've seen family members who don't agree on placing their loved ones in the hands of hospice simply because they're going on information that was relayed to them from a confused family member. Rather than realizing that death is right around the corner and making the time they can with the family members quality time, they're scrambling to find cures that don't exist and fighting over what's best for mom. I recognize that often when patients are older and the 2 people who are sitting with the doctor learning of the diagnosis, that the sick one and the spouse is there, the diagnosis is overwhelming, and sometimes they're only basically catching every other word, so it becomes a not fun game of, the orange juice can and the words just don't get through. And my hope for healthcare professionals is that it gets back to the day of the old-time country doctors, that every part of this end-of-life journey matters. And for me, taking the time with the family, not just, I have to tell you, and this probably is politically incorrect, but I hate HIPAA laws. I hate HIPAA laws. And I'll tell you, because when someone's sick, it belongs to the whole family, not just to the one person sitting there that's translating all of the doctor said this and the doctor said that, and then those family members are all, half of them are left in the dark. And hence, as the time grows nearer to the end of life, everybody's wanting to do something different. I really wish that doctors and all of that are concerned would gather and really, really talk to them about getting all the family members in that room and talking about what's going to happen in the next few weeks, in the next few months, however long it's going to be with the entire family members, because it's only fair, it's only right, because that's such a precious, precious time. And so often it's just that one person relaying the message to one another. And I look back on my mom and having 8 brothers and sisters and being the youngest and sort of kind of being in charge of everything. And I don't know why, but there was so much that needed to be shared with everyone. And if we all could have been in the room at the same time when that diagnosis came, it would have been so much clearer. And that end of life time for my mom, through Nathan Adelson Hospice, they knew the right thing to do. And I have to tell you, I have a friend whose father died recently, maybe 3 years ago at hospice, and they had not had the end of life talk. And I sat there with my friend in the hospital room, and she was shocked that her father died. After 5 years with Alzheimer's and many, many, many other things going on, she was shocked. And I sat there after her father died, calling funeral homes, calling this, doing that, getting pricing. And she was arguing with her sister, and her sister didn't know how this happened. And I guess as the voice, and it says on your thing that it's the voice of a patient. The voice of the patient, let me tell you, my mom, Evelyn Newman, who was the smartest woman I know, ever knew. She never had a mother. Her mother died when she was an infant, and she was pretty much just raised on the streets of New York. And here she had these 9 children. But what she did, this gift of writing these words down so that when it was done and when it got down to it, we knew what to do. And it wasn't hook mom up to this. It was clear. And back then, think of that, back then in 1986, she wasn't talking hospice. She didn't say put me in hospice, but she was saying, let me die with dignity. Please let me die with dignity. And I just encourage anybody out there to please, as healthcare professionals, consider the entire family. Throw HIPAA out the door. And just let everybody that's concerned give that patient that time to be with their loved ones at the end so they can take that quality of time. Thank you.
Did you get Mom? Oh, okay. Thank you, Nora, about telling us about the wonderful program that's beginning at Nathan Adelson, and also for Laura for sharing the story about your mother who had such insight and to share her wishes with you, and for you all to comply with those wishes as well. So thank you for sharing that. Wyatt, I'm wondering if we have any comments related to what Laura had to say, or any questions along those lines yet? No? Okay. How about anything else that we want to cover? We do have a little time. We might even be able to go back to Mark or Mike if there's other thoughts that we wanted to mention. I'll give you just a moment. I kind of caught you off guard there.
Yeah, Deborah, we actually did have a comment during Mike's section. This is Laura commenting, we need to be more invested in learning about patient engagement from the patients instead of assuming we know how to do it. Great comment and perspective as we just learned from Laura.
Right. Well, and thank you. You know, a lot of times it's like, oh, well, we're all patients, or we'll know how they would like the lounge set up, or we'll know. And it's like, oh, well, I guess we could ask them, that we build these things for. So I think that's, it's kind of that paternalistic approach that often we've grown up with in healthcare, I think.
Another comment, Deborah, that came in through our web form, and this refers to a comment that Mike made. I challenge, it is not about the patient, it is about the person before they become a patient. I think that actually went back to Mark's first point about patient needs to be the center of our system. This individual feels like it needs to be the person before they become a patient.
Yep. And I think Mike alluded to that as well, about if we keep healthy and don't become patients, then that's really what the ultimate goal is there, I think.
And Deborah, one more comment relative to Nora and Laura's presentation. Catherine comments, very timely information. I am planning on chatting with my own parents about this over Christmas break. The only time I can round up everyone and have their attention. Cookies and hot cocoa to sweeten the deal.
It sounds like a nice plan. I know some families do that over Thanksgiving or other kind of holiday times when you are all together and you're feeling thankful for each other. And I think it's a real gift that we can give each other so that people know what you want. Mike?
Yeah, we could request comments, that sort of thing. What opportunities are there? We had a challenge from Nora that how can we initiate those conversations as providers?
Okay, so Mike just challenged us to chat in. How can we provide for those opportunities as providers? What and how can we create opportunities to have those conversations with our patients? And, we also have families too. So how can we do that even with our families? What is it that we can do? How do we create those opportunities? There's a number of references. I think Nathan Adelson's will be great. There's one the conversation or start the conversation, something like that. I don't know if others have, is there any other comments that Laura or Nora would want to make? Sure, come on up. Nora's going to join us here. Thank you.
Yeah, you're right. There are many resources that exist that are good, that provide good toolkits. One of them is called Consider the Conversation, I think is the one that you mentioned, the Conversation Project. There's another one called Death Dinners the person who wrote in about having that conversation over Thanksgiving. They have some really good tools on their website, death dinners. They have websites. Our CEO actually participated in one, and she was filmed by a news station doing that. And it was the whole family getting together. They try to make it a little bit light so it doesn't seem like, okay, we're going to have this conversation about. And so, they provide ways to start. They have things that you can use when you see things on the news, or everybody's experienced family members or friends that things happen and maybe things don't go as planned. And obviously people get resistant sometimes, like, no, we don't need to talk about that now, or you're totally fine, let's not talk about that. And so sometimes we have to, kind of push back a little bit and say, yeah, this is why this is the great time to talk. When I first started working at hospice and learned about this, I actually did go to my parents right away and say, oh, you really have to fill out your advance directives. I want to know in case anything happens. And they said, well, what are you talking about? We're totally healthy. Are you trying to kill us now or what? And, if anything happens to me, just shoot me. I'm like, no, that's not a plan. That's illegal. And you're not writing that down. So, I couldn't get them to fill out their advance directives, but I actually did mine, and we were using the 5 wishes. That's another tool. Aging with Dignity is the name of that organization. The person that started that used to work with Mother Teresa. So that's called the 5 wishes, Aging with Dignity. And so I completed my 5 wishes and, sat down with my parents to talk to them about it. And then they thought it was great and they wanted their own. And now they've done theirs, and they constantly ask to borrow, or to have more of those forms so they can give it to their friends and family. Those are available in like 30 different languages. And that one specifically is written in a very simple, like not so legalese language, yet of course it's a legal document. So those are some other tools. There's someone who has their hand. Okay. The 5 Wishes is its own organization, and you can purchase them. They're $1 each, and you can purchase them from them directly. With our Deciding Tomorrow Today campaign, it's a similar concept in terms of providing tools and forms that people can fill out. Those will be available on our website.
Thank you, Nora. That's really helpful. You can go in and chat your questions, and Wyatt does have a couple of comments and a couple of things that he's going to bring forward. But in the meantime, go ahead and chat in. That's the easiest way for us to talk about those. Wyatt?
Yes, a comment from Barbara. My daughter's 24, and due to the work I do, we always have medical durable power of attorney in place and 5 wishes completed. This keeps families from burdening with guilt and guessing at a time of crisis. It is never too early to have these conversations with our families. Another comment, Deborah, from Catherine. Sometimes providers see multiple members of a family when one passes away, asking how the surviving are doing and asking how the experience was. Then ask if they have their wishes written down. Give a resource toolkit online to help get them started.
So when somebody does pass, it's an opportunity, if you haven't already, to go ahead and complete those things or think about those conversations.
Another comment from Daryl. Great book about this very subject, available on Amazon. The Sandbox Wars, End-of-Life Decisions, the Most Important Gift to Your Family. Too many comments coming in. I just lost it. By Stephanie Payne, author.
He's reading as fast as he can.
Discussion of the POLST form, Physician Orders for Life-Sustaining Treatment form, is another way providers can broach the subject with patients and families. Go to, this was for an Oregon chat, or or.polst.org. I'm sure there are similar in each of our locations.
Okay. I know when I first sat down with a friend of mine and my husband to talk about what we wanted, or mostly it's what seems like it's what you don't want. And as I was just looking at the guide that you handed out, and you say, well, I don't want to suffer. And then you take another, like, well, what does suffering mean to you? I mean, because it could be different than that. And so it's not really like something that you just do at the spur of the moment, I don't think, or, quickly like that. I mean, it really is thought and really does make you think in a different way about what you do want, and how you want to share that with others as well. Oh. And I do know a lot of our staff have been very active with helping nursing facilities in Nevada fill out and providers understand the PULSE, which is an actual order set so there's an order from the physician that is carried out at you have to be, like, I think, terminal and within 6 months of dying or something like that. So the advance directive is, for anybody at any age and that sort of thing. And as you mentioned, they have them in Oregon, and I know Utah, and like you said, probably New Mexico as well. You have another point?
Yes, actually a question and an answer.
Okay.
A question from Patricia. How can these discussions be incorporated into primary care? Needs to be reimbursed. And covertly, Mike Silver slipped me a note where he referred to, this was before the question came in, that the annual wellness visit through Medicare is a reimbursable visit that includes end-of-life planning as part of that visit and assessment with their Medicare patients.
So I think that's really helpful for people to know that the doctor is compensated. And sometimes, it's not that comfortable for the doctor to bringing it up too. I mean, I know for my father, he had the physician, I don't think he ever would have brought it up, but he had sort of a temporary physician that was working with him, and she took care of Dad for a while, and we were just going to the hospital all the time. And she's like, have you ever thought about hospice? And like, yeah. And I tell you, we never went back to the hospital again, and he would do really, really well, and then he would do not very well. But it was, really that love and support that it made all the difference. It was as good as it could have been that way. And it was at home. It was at home, so that was beautiful. Okay.
A couple of additional resources referred to from New Mexico. The great resources for families in medical crisis to facilitate communication, www.caringbridge.org. Also, the National Pulse is available at www.polstpulse.org.
Okay. Very good. Very good. Well, thank you all for sharing all those resources and your stories. Laura, we thank you so much for that. And your mother would be very proud of how you've carried on for her. So that said, we're a little ahead of schedule, but we're going to go ahead and wrap up here. How about if we have another round of applause for our great speakers this morning? So some of the highlights, and again, this is a place where you can chat in. What are some of your takeaways? What are some of the highlights from the experience you've had this morning? You can also tweet those, certainly. I think Mark gave us a great overview of the impact of the cost of healthcare and what that really does, what that means. The thing that hit me there was it takes our pay raises. Wait a minute. It gives me a good raise, and off it goes. I don't really get it after all. It just seems like that. I also thinking about joy in the workplace, and kind of that links very well to Mike's talking about burnout and the role of resilience. I've been a nurse a long time, and I know when I work now with people in nursing facilities or hospitals or other settings, it's really not what most of us had in mind when we first decided to go to school to do this. It's a heavy weight, all that paperwork and the computers and, all the changes and HIPAA and all the different things. It's easy to get burned out. It's easy to get burned out and not feel that joy. I was really excited. I had heard about the 3 good things before. We've done that a couple of times, but I had never I thought Brian did a great job of talking about really the science and the research and the study at Duke. That's no small potatoes there. It seems like the real deal. And really the impact of just saying 3 good things every day before you go to bed. That's pretty remarkable. And that we have an opportunity to participate in something like that too, nationally, be part of that research. So that's one thing I'm gonna do. I think that's and I think we could do that, in the workplace to remind each other to do that. I can send an email. We send emails for other things at 8 o'clock at night at Health Insights, so we could probably do that's sort of an inside joke there. Let's see. The importance of the patient's voice. Again, thanks to Laura for sharing her very personal story with us, and for Nora to sharing the great work that they're doing at Nathan Adelson. There's great hospices in all of our states and across the country, and they're a real resource to us, and I know they're happy to come and talk about their programs and to your organization if you want to know more about how you can get involved in that sort of thing. We like stories, and I could relate to Mark's mother-in-law, and I love and her iPhone and the what she pasted on the back of it, and I think a lot of staff could understand that I could relate to that story very well. So I thank you for sharing that. Again, why don't you go ahead and chat in your thoughts of what you're going to be taking away, and we'll have Wyatt in a moment kind of look at that and share those things with us. Again, you can't get away from this word, and that's action. That's what we want you to be thinking about as we move into the afternoon. And just, kind of think about, you've got your workbooks there or your note cards, whatever, what kind of ideas for change have come into your mind? Did you talk to somebody, or did you hear something in the chat? Did somebody mention something that said, oh, I never thought of that. That might be something that I could do. Did you learn something from somebody that you spoke to? I'm sure that you did. Did you learn something from going to the poster gallery maybe? Did you say, anything that made you say, something you'll do differently? And then again, you've had the opportunity to be with us, but what are you going to do when you go back to your organization? How are you going to share what you've learned? You can certainly share 3 good things, but there's a lot of work here and there's a lot of good information here. So how are you going to share that? As part of the network. Remember, we're creating that network among us. So again, jot it down, talk with people over the break, and think about what you're planning to do. Oops, I went back too far. Sorry. So evaluations. Time flies, right? It was just early morning, and now it is time to do the evaluation. So again, we have a couple different ways for you to do that. So you can scan the QR code out of your workbook on the cube. You can also go to this web address if you'd like to do it electronically by going that route. For those of you that are in person, there's a hard copy evaluation on your table. And so we really do appreciate if you take some time to fill that out. And there'll be a designated place in each of your conference rooms where you can leave those with us. And let's see. I guess you can also click the evaluation link in the chat, in your chat box there, and you can do it that way. So a lot of different opportunities. We really do, this was a first of a kind event with a lot of different sort of moving parts. So we're interested, how did that work? Was it disruptive? Did you feel involved if you were online, that sort of thing? Because that's really our goal. Like we said, we're going to do mini lands over the quarterly, and then we'll come back every year for another session sort of like this. But based on your evaluations, it could be quite similar to this, or it could be quite dissimilar, depending on what you think worked well and what didn't work so well. So we really do appreciate your taking that time to think about it and actually even write words. You probably have a chance to circle some numbers, but words help us even more than the numbers do. So that said, again, we're a little ahead of schedule here. The bottom of the hour, we're going to take a break for about an hour. And people on site, your local host, is going to have some instructions for you about what happens during the break and what happens after the break. So we'll stay tuned for that. And those of online, after we hear from some final words from Wyatt, you're going to be disconnecting from us and then reconnecting for the afternoon sessions. And I'll tell you about that in just a moment. Let's go to some final good words from Wyatt and all of you.
Not much coming in, Deborah, after our previous discussions. Just some more comments about patient engagement, that they'd like to hear more about the social determinants of healthcare.
Okay.
That needs to be front and center in our discussions with patients. And again, some pleas for reimbursement of providers to help support this type of true engagement.
Okay. Well, and I think, Mark talked about incentives, their roles, and talked about payment reform, and I think that will help us to reach those kinds of goals. And so I think people that are concerned about that are going to see big change in that area as well. So, well, with that said, what's next, as I promised, is a break. And so you will have time, if you're in the room, to do some networking. For those that will be leaving us now, you can disconnect. We want to thank you so much. It's generally a disadvantage not to be in the room with others, but we hope we've created some opportunities for you to feel like you're connected to us. We're going to, like I said, take an hour's break, and then we're going to ask you online participants to reconnect by selecting the first breakout session that you want to attend. There are 3 breakout sessions, and again, you can do it on screen, or here's the website. So if you're online, you can choose your and connect to your breakout session that way. The breakout sessions, there's one on health information technology, there's one on patient engagement, and there's one on process reliability. So again, pick which one you want to do first. This afternoon, those will be hour-long sessions. We'll have a 15-minute break, and then you'll be able to choose a second session to participate in. So that said, we will see you in about an hour. Folks online, it's been great having you. Thank you so very much for your patience and for being with us. And if not before, we'll see you probably around this time next year. So thank you so very much. Have a good afternoon. If you would just stay seated for a moment, I have some more instructions when we're off the air. Say it again. Oh, okay. Okay. So let me just give a few more particulars. Our food is just getting here, so there's no place to get up and go to right now. So when they get the food delivered and set up, I think it'll probably be in the back here.